Good evening, everyone. Thank you for joining me today. I will be presenting research on the impact of conditional cash transfers on the utilization of maternal and child healthcare services, specifically focusing on the Janani Suraksha Yojana in India. The Janani Suraksha Yojana is a government initiative aimed at reducing maternal and neonatal mortality by incentivizing institutional deliveries. Our research seeks to answer a critical question: how effective are these conditional cash transfers in increasing the use of maternal and child healthcare services? By the end of this presentation, you will see how JSY has impacted healthcare utilization and how can we assess the broader implication of such programs. So let's begin by taking a look at the structure of this presentation. We will cover several key areas, starting with the abstract and introduction, where we set the stage for our research questions and its relevance. Next, we will dive into the Janani Suraksha Yojana and provide an overview of the program and its goals. We'll also discuss the data used for this analysis. Following that, we'll walk through the methodology employed in our study, outlining this approach we took to answer our research questions. After the methodology, I will present our results, showing how conditional cash transfers like GSY impact the use of maternal and child healthcare services. We will also go over our robust analysis, ensuring the findings are reliable and well tested. Next, we will explore the heterogeneous effects, analyzing how the impact may vary across different populations or regions. Finally, we conclude with the conclusion, summarizing the findings and discussing their implication for policy and further research. Now, let's dive into the key details of our research project. So, the abstract includes firstly the context of our study. The Janani Suraksha Yojana is a conditional cash transfer program in India that incentivizes pregnant women to deliver in health institutions instead of at home. The goal is to improve maternal health by ensuring that deliveries take place in safer and more sanitary environments. The data used in the study is based on DLHS 4 2012 to 13 data set, a more recent and higher quality survey compared to DLHS 2 and DLHS 3. This data helps us understand the full effects of the JSI program after it had matured. In terms of methodology, we employed two causal inference techniques: propensity score matching to estimate the average treatment effect on the treated, and fuzzy regression discontinuity design (RDD) to estimate the local average treatment effect, using birth order equal to 2 as the policy cutoff. Our findings indicate that institutional deliveries increased by approximately 16 percentage points under the JSI program, while the late estimate around 23 percentage points, shown as an even stronger causal effect near the eligibility cutoff. Finally, the conclusion: the results show that JSI significantly improved institutional deliveries rates, with the impact being larger than earlier studies that use the older data sets, demonstrating the growing effectiveness of the program over time. Let's now look at the introduction to understand the motivation behind our research. The policy problem we address is the increasing need for maternal and child healthcare services. While expanding the supply of these services is important, it's often insufficient when affordability is the primary constraint for disadvantaged women. Over the last 3 decades, the policy response has largely been demand-side financing, where conditional cash transfers have been used to raise the purchasing power of these women, enabling them to afford institutional deliveries. However, prior international evidence on the effectiveness of such programs is mixed. Some studies show that these programs raise institutional deliveries and antenatal care, while others show no effect on the specific services. This inconsistency highlights a crucial gap, which is why our research aims to provide a clean, context-specific causal estimate of how large-scale cash transfers, like GSY, impact maternal and child healthcare utilization in India. So let's continue with a closer look at the Janani Suraksha Yojana, which was launched in 2005 under the National Rural Health Mission. JSY provides cash incentives to pregnant women, mainly to encourage institutional deliveries. Additionally, it covers at least 3 antenatal care services, including tetanus vaccination, iron folic acid supplementation, and at least 1 postnatal checkup for the mother and newborn. Earlier studies on JSY relied on prior district level household services, particularly DLHS 2 and DLHS 3, which include data from the pre-implementation and early rollout periods. However, many births before 2007 were misclassified as JSY recipients, which caused one-sided non-random treatment errors in the estimates. The consequence of these issues is downward bias intent to treat estimates. Instrumental variables including techniques like propensity score matching or district level differences in differences cannot adequately correct for the misclassification or removing time varying observables. District level differences only help mitigate heterogeneity at that level. Therefore, the need arises for re-estimation using data that aligns with the full program maturity, ensuring accurate measurement of the JSY's effects. To ensure the data we use aligns with the full program implementation, we have chosen DLHS 4, which includes births from 2008 onwards. When JSY was fully implemented, however, the trade-off is that this data lacks national representativeness. Despite this, it still covers about two-thirds of the Indian states, including those that resemble low-performing states. For identification and estimation, we use propensity score matching with a logic transformation to logouts, applying nearest neighbor matching. We also focus on managing missing education variables for each couple by considering two sets of covariates. Regarding diagnostics, we follow established recommendations for sensitivity checks to identify hidden bias. We also perform overlap assessment with trimming of extreme propensities and post-matching balance checks. Additionally, we use fuzzy regression discontinuity to apply the birth order to eligibility rule. This helps us identify the local average treatment effect for those who comply with the program criteria. Finally, regarding heterogeneity, we expect different effects across time, state, wealth group, and provider types. Specifically, we anticipate larger effects in poorer women and those using public health facilities. So, let's try and dive into the details of the Janani Suraksha Yojana program. India has made significant strides in meeting the infant mortality (MDG), but it still accounts for around 22% of the globe, under 5 deaths. The maternal mortality ratio has fallen from 212 to 178 per 10,000 live births, but there are still wide state level gaps, with states like Assam having an MMR of 328 compared to Kerala's 66. The eligibility criteria for JSY differs by region. In low performing states, all pregnant women delivering in public or accredited private facilities are eligible. In high performing states, the focus is on disadvantaged women, including those from backward castes or tribes, women aged 19 or older, and those having no more than 2 births in public or accredited private facilities. ASHA workers, also known as accredited social healthcare activists, play a crucial role in JSY. They identify and register women for at least 3 antenatal care visits, arrange facility care and newborn immunization, ensure postnatal care within 7 days, and provide counseling. They help with institutional delivery and family planning and escort women to the hospital, ensuring they stay until discharge. Cash is paid at the facility for public deliveries. The full amount is paid at the first visit. For private facilities, one pays at first visits with the remainder at delivery. Extra incentive for C-section or complications are provided and transport costs are covered. ASHAs receive an incentive in 2 installments, one after the first visit and one after postnatal care uptake. When it comes to cost and facility choice, JSY acts as a cash offset, helping cover delivery costs. Public facilities tend to have a larger share in rural areas, with around 50.42% in rural SNCs, while most JSY deliveries occur in sub-district or district hospitals. Interestingly, while the coverage share in private hospitals is low, around 8.6% in rural areas, most JSY deliveries occur in public hospitals due to the cash offsets and lower delivery costs in public settings. In conclusion, JSY's influence on maternal and child healthcare is visible through its support for institutional deliveries, particularly in rural and disadvantaged regions where access to private healthcare is limited. Let's now take a look at the data used in our analysis. The survey framework we used is based on DLHS 4, which is a repeated cross-section of 18 high-performing states and 3 union territories. This was selected to align with the mature implementation of the JSY program. We did not use earlier DLHS 2 and DLHS 3 data due to concerns around misclassifications. The analytic sample includes data from 378,487 households with 76,847 women aged 15 to 49 who had their last birth after 2008. A small number of responses were excluded due to non-response or because they were recipients of other schemes. In terms of treatment versus control, the JSY share is about 21% with 15.8 thousand treated women versus 57,000 controls. The treated women tend to be poorer with a below poverty line rate of 0.469 versus 0.318, a wealth index of minus 0.654 compared to 0.016, and they are younger with an average age of around 23.85 versus 25.05 for the control group. Treated women also have lower parity, that is 1.84 versus 2.16. Tribal status shows no significant difference. For the covariates and propensity score matching samples, we consider factors such as below poverty line, scheduled castes, scheduled tribes, age, parity, wealth, education levels of both the mother and her husband, and state dummies. In our sample, sample 1 includes all covariates, while sample 2 drops the education variables to increase the sample size. Outcomes and grouping focus on key maternal and child healthcare services, including any antenatal care, institutional delivery, postnatal care for the mother and the baby, and infant immunizations. Since immunization sample sizes were smaller, we grouped the outcomes into type 1 non-immunization and type 2 immunization. The raw mean gaps suggest GSY favors better outcomes but require further estimation using PSM or the fuzzy regression discontinuity techniques for causal inference. Now let's discuss the methodology used in our study. The core causal targets are the potential outcomes for each woman. For each woman, we define two potential outcomes, Y1 with GSY and Y0 without GSY. The treatment W is defined as belonging to the set 0, 1, where W equal to 1 indicates treatment and W equal to 0 indicates no treatment with GSY. We assume the stable unit treatment value assumption, meaning that one woman's treatment only affects her own outcome and does not affect the outcomes of the others. We discuss the average treatment effect, that is the average effect of the program in the population, against the average treatment effect on the treated, which is the average effect of the program among GSY recipients. Under the assumption we will cover, we assume that the average treatment effect for covariates would be equal to the average treated effect on the treated for the same covariates. The assumption 1, ignorability, that is also unconfoundedness, assumes that conditional on observed covariates X, the treatment W is independent of the potential outcomes Y0 and Y1. This assumption holds unless the covariate X omit important confounders or include post-treatment variables. The second assumption of common support or overlap assumes that for all covariate X, the propensity score lies strictly between 0 and 1. In practice, this is enforced through propensity trimming, which ensures that sample consists only of observations with non-extreme propensity scores. We use propensity score matching to estimate the probability of receiving the treatment based on observed covariates. First, we estimate the propensity score using a logic model and transform it to log odds. Next, we match treated women to the third nearest neighbor to impute the counterfactual outcomes for the treated groups. The average treatment effect on the treated is calculated as the mean difference between the observed outcome for treated individuals and their matching counterfactuals. For each outcome, ATT uses the common observations across that outcome and all relevant covariates in the logic. This means that the sample size and logic coefficients can vary by outcome as they depend on the specific characteristics of each group. One critical assumption for matching is that there is overlap in the treatment and control group, meaning that for each individual there is non-zero probability of receiving either treatment. To ensure balance between the treated and control group, we inspect propensity density plots. Any observation with a propensity score outside the range of 10% to 90% are trimmed. Post-matching covariates balance is also checked, ensuring that any bias have been minimized. While we have no evidence suggesting violation of the ignorability assumptions, we do acknowledge the potential for residual endogeneity. To address this, we implement fuzzy regression discontinuity, which takes advantage of the birth order eligibility rule, that is a cutoff at birth order equal to 2. This provides a strong first stage useful for estimating the local average treatment effect. However, the age 19 cutoff had an insignificant discontinuity, so that has been discarded due to the lack of meaningful observations. For each outcome, we discuss two logic models of the GSY indicator under sample 1 and sample 2. We transform the propensity to log odds, apply third nearest neighbor matching, and compute the average treatment effect on the treated with bootstrap standard errors. The ATT for each outcome uses common observation for that outcome and all relevant covariates in the logic model. As a result, sample size and logic coefficients can differ across outcomes. For example, the outcomes for institutional delivery and the vaccination are probed by similar sample sizes and representative logic coefficients. Our findings show that the strongest positive predictor of receiving GSY are below poverty line, schedule caste, and tribal affiliation. Additionally, wealth index, age, parity, and years of education of the woman and her husband are negatively associated with GSY receipt. While residence and religion show positive associations, to ensure validity, we address overlap and balance using propensity density checks, trimming observation with the propensity score outside the range of 10% to 90%, and conducting post-matching balance tests. Average treatment effect on the treated estimates are reported with bootstrap standard errors and conventional significance levels. We also make comparison among eligible non-participants with ineligible individuals within the control group. This comparison reveals small differences supporting comparability across groups alongside the matching groups. Finally, sample 2 effects tend to be larger because dropping education at variables increases the number of control group individuals and raises the share of poorer controls. This reduced control means and moves ATT estimates closer to the raw difference. For institutional delivery, the average treatment effect on the treated is 0.125 in sample 1 and 0.157 in sample 2, with both estimates being statistically significant under p lesser than 0.001. For at least one postnatal care for the mother, the ATT is 0.101 in sample 1. In sample 2, it is 0.122, again with high statistical significance. For at least one antenatal care, the ATT is 0.079 in sample 1, and in sample 2, it is 0.101, with again significance level of p value under 0.001. Previous authors also report estimates of 0.100 and 0.115 for at least 3 ANC visits. For at least one PNC for the baby, the ATT is 0.070 in sample 1 and 0.086 in sample 2, with all estimates being statistically significant, p lesser than 0.001. So the largest impact of GSI program is on institutional delivery, which has the highest ATT estimate. All four intended outcomes, institutional delivery, maternal PNC, ANC, and infant PNC, improve significantly with GSY. Additionally, the effects are consistently large in sample 2 due to the composition of the sample. The largest gains in antenatal care are seen for iron folic acid supplements, which increase from 0.104 to 0.125, and for tetanus vaccination, which increase from 0.097 to 0.117. Other significant improvements include weight gain, blood pressure, and blood group testing. Smaller but still significant increases are seen in the abdominal exam and ultrasound. However, only iron folic acid and the tetanus vaccinations are included in the GSY benefit package, with all other maternal care and healthcare mother-child healthcare services being unintended outcomes of the program. There are moderate clustered increases in outcomes like abdominal exams, breastfeeding advice, and family planning advice. These increases are especially meaningful given the low baseline use of these services in the control group. For the baby, we observe an increase in weight taken at birth and a decrease in the days to first breastfeeding, including earlier initiation. Additional positive effects include advice on diarrhea and pneumonia. Immunizations outside the GSI benefit package. So this program also significantly impacts immunization rates for hepatitis B and vitamin A. The first polio dose within 2 weeks, also shows a significant increase. Smaller but still significant improvements are observed for BCG, DPT, and measles, consistent with the spillover effect of GSY through information and contact via ASHAs and facility visits. After matching, the percent standardized bias, including state and year dummies, drop to near zero and remain within the plus minus 10 across all four representative logic models. This indicates that the matching process has successfully balanced the covariates between the treated and the control group. We observe that propensity score densities show a control mass near zero. After applying crumb trimming at a threshold of p greater than 10%, we estimate the main outcomes. The ATT estimate remain close to those as indicated in the earlier results, confirming that the lack of support is not driving the results. In the GSY logic models, below poverty line and scheduled caste are the strongest positive predictors of GSY receipt, with age, parity and wealth being negative predictors. Additionally, rural and religion individuals are also likely to receive GSY. These effects are consistent across different outcome models. The effects are particularly strong in the larger sample too, which includes a broader set of variables. We tested 5 different sets of covariates, including the program criteria only, self-selection, state fixed effects, birth year fixed effects, and district fixed effects. Once we control for state and year, the ATT estimates align with those in sample 2, while the program criteria only models using covariates 1 yields divergent estimates. We tested ATT estimates for the main outcomes using different matching techniques: one-to-one, radius, kernel, local linear, and spline matching. The differences between methods are minor, and all effects remain statistically significant, further confirming the robustness of our findings. So, continuing with the robustness analysis, we performed additional tests to further validate our findings. Within the control group, we compare eligible non-participants to ineligible using ordinary least squares with covariates. Several outcomes show significant differences, but the magnitudes are modest. This suggests possible selection on unobservables, although these differences are not large enough to explain the main results. For the 4 main outcomes across both samples, the upper and lower bound tests yield p-values near 0 across all gamma values. This result indicates that we reject the possibility of systematic over or underestimation due to unobserved factors. In conclusion, together with the balance and overlap checks, the evidence does not indicate meaningful violations of the ignorability assumption for the propensity score matching estimates. However, we acknowledge that small residual endogeneity cannot be completely ruled out. So, the primary aim of this approach, that is, now we explore the robust analysis using a fuzzy regression discontinuity design, is to address residual endogeneity by exploring the GSY eligibility change at birth order equal to 2. This eligibility rule serves as a natural experiment to estimate causal effects. The age 19 rule is dropped out due to weak first stages. The fuzzy regression discontinuity relies on local randomization around the cutoff and ensures monotonicity. The first stage uses instruments z equal to 1 for birth order less than equal to 2 and z multiplied by birth order minus 2 for birth order greater than 2. We include covariates in both the first and second stages to handle any kinks in the covariates, restricting the bandwidth to birth orders 1 to 7 due to discreteness and data diagnostics. Observations concentrate at birth orders 1 to 2 and drop sharply after birth order 2, indicating potential measurement error. This motivates using the 1 to 7 birth order window for the analysis. At the cutoff, GSY take-up shows a small discontinuity of about 0.069 without covariates and 0.087 with the covariates, accompanied by a clear kink. The main outcome exhibits strong kinks but minimal jumps. The two-stage local linear estimates adjusted for covariates produce large late estimates than PSM ATT estimates. For institutional delivery, the late estimate is approximately 22.7 percentage points, whereas the ATT estimate is 15.7 percentage points. This result is consistent with stronger effects for compliers at the eligibility margin. Here, as we see, figure 1 shows the jump and kink in the probability of participation in GSY at birth order equal to 2. As the birth order increases, there is a noticeable discontinuity at the cutoff, indicating a sharp increase in GSY participation for women with a birth order of 2. The scatter points represent the mean GSY dummy value for each birth order, while the local linear regression line is estimated on either side of the cutoff. This graph clearly demonstrates the discontinuity and kin relationship between GSY participation and birth order. Whereas figure 2 illustrates the probability of receiving key maternal and child healthcare services at each birth order. The outcome shows similar discontinuous patterns around the cutoff. For example, the probability of institutional deliveries, ANC visits, and PNC for the mother and baby increase significantly as birth order approaches 2. This confirms that the GSY program significantly affects the health outcomes with stronger effects for those at the eligibility margin. The first figure in this slide shows the standardized bias across covariates before and after matching. The scatter points represent the standardized bias for each covariate before matching and after matching in panel A and B for sample 1 and sample 2 respectively. We see a marked reduction in bias after matching, indicating that the matching process has been successful in balancing the covariates between treated and control groups. The second figure presents the density of propensity scores for both the treated and control groups in the matching process. Panel A and B show the density for sample 1 and sample 2 respectively for two different outcomes. The propensity score distribution for the treated group and the control group is displayed, while the overlap showing where matching occurs. The density is higher in the overlap region, suggesting that the matching process is effective in creating comparable groups. The estimates presented are average treatment effect on the treated. So now, in order to get an idea about the heterogeneous effects across different states, within specific strata, using the same knowledge specification and third year standard, propensity score matching are used in sample 2. Therefore, while the effects are comparable across strata, they do not capture causal differences between those stratas. The stratification for the analysis include wealth percentiles, the year of the last live birth, state, and the place of last delivery. For analyzing the institution type, PSM cannot produce separate entities for institutional delivery due to limited within facility variation. Therefore, we run OLS regressions with interaction between the treatment indicator and facility dummies, along with the full sample 2 covariates. These conditional effects align closely with the results from the PSM analysis conducted in the previous checks. The assumption emphasized by the authors include using the same covariate sets and matching methods across groups. The results are delivered within the DLHS4 high performance sample frame for the time-based plots. The stability of trend suggests similar exposure pattern for both treated and control groups from 2008 to 2013. By wealth, the GSY effects are the largest for poorest and decline with increasing wealth. The sharpest drop is observed from 0 to 20 percentiles to the 20 to 40th wealth percentile. After this, the effects moderate for the middle wealth group and then flatten or mix afterwards. This suggests that GSY has a stronger impact on the poorest women with diminishing returns as wealth increases. Over the period from 2008 to 2013, there is no clear trend. The ATT estimates remain stable for all main outcomes, indicating that both treated and controlled women gained facility exposure at similar tests over time. The highest ATT estimates are observed in states such as Meghalaya, Andhra Pradesh, Nagaland, and Tripura, while the lowest effects are seen in more advanced states like Kerala, Karnataka, Tamil Nadu, Pondicherry, and Telangana. The higher impacts in the northeast states suggest that more active frontline workers and lower baseline access in these areas lead to larger effects. By institution, GSY has larger effect in public facilities compared to private hospitals across all main outcomes. The conditional effects for institutional deliveries in public facilities are approximately sub-health centers with 31 percentage points, primary health centers with 27 percentage points, community health centers with 28.5 percentage points, urban health centers with 21.3 percentage points, and private hospitals with 18.6 percentage points. The findings suggest that GSY works best among the poorest, especially in backward and northeastern states. Recipients prefer public facilities over private ones, even though private hospitals offer lower cost averages. This indicates a stronger preference for public services, particularly in sub-district and district hospitals, despite higher private sector accessibilities. Now, The first figure here shows the effect of GSY on main outcome by state. The graph highlights the ADT estimates for different outcomes across various high-performing states. We observe that states like Himachal Pradesh, Arunachal Pradesh and Nagaland show the largest effects, with particularly strong improvements in institutional delivery and postnatal care. In contrast, more advanced states like Karnataka and Kerala show smaller gains, reflecting differences in baseline access and program implementation. The next figure shows the effects of GSY on main outcome by the year of last life birth. The graph represents the ATT estimates for each year between 2008 and 2013. We see a general trend of improvement across all outcomes over time, with a slight leveling off in more recent years. This suggests that GSY impact on maternal and child health outcomes remains stable, with consistent effects across different birth cohorts. The last figure presents the effects of GSY on main outcome by percentile of wealth index. As expected, the wealth effect of GSY are strongest among the poorest wealth percentiles, with diminishing effects as the wealth increases. The sharpest declines are observed between 0 to 20% and 20 to 40 percentiles as discussed previously, highlighting that the poorest benefit the most from the program. So, in conclusion, this study examines the effects of Janani Suraksha Yojana, a large conditional cash transfer program aimed at improving maternal and child healthcare services in India. GSY is a large-scale program that targets over 11 million women annually. This study uses DLHS-4, focusing on women who gave birth after 2008, and excludes beneficiaries of other schemes, thus addressing biases seen in earlier estimates from DLHS-3. The treatment dummy issue in earlier studies, which led to endogenous treatment assignments, is resolved here. The primary estimates are based on propensity score matching with rich covariates. Balance and overlap between treated and control groups have been verified, and the Mandel-Hassel bounds provide no evidence of hidden bias. A fuzzy regression discontinuity design at birth order equal to 2 is used to supply instrumental variable-based local average treatment effects, assuming local randomization and monotonicity, with residual endogeneity being acknowledged. For the main outcomes, we find that the average treatment effect on the treated for institutional delivery in sample 2 is 15.7 percentage points. The fuzzy regression discontinuity based local average treatment effect are higher, with the institutional delivery effect at 22.7 percentage points, and at least one PNC for baby at 8.6 percentage points. These effects exceed prior estimates from DLHS-3. Immunization gains, while smaller, are still positive. The largest impacts are seen among the poorest and in poorer states. Women receiving GSY tend to shift towards public health facilities, even at lower cost coverage shares, indicating a preference for quality in public facilities. The study suggests lightning targeting to disadvantaged groups and improving quality at public hospitals. Long-run child productivity gains are plausible but not measured in the study. The DLHS-4 data is not nationally representative, and future work should focus on high-focus states with designs like references and differences. Even so, by minimizing treatment misclassification, these estimates are likely closer to true national effects. Thank you for your time and attention. I hope you found this presentation insightful and that the findings provide valuable perspectives on the impact of GSY. I look forward to any questions or feedback you may have, and I would like to denote all the credit regarding this research to Dr. Rahman and Dr. Sasindra Palikadawat. Thank you.